Okay, good evening, everyone. Thank you very much for being here today. Before we begin, I'd like to mention that this is my first presentation in English. I don't get to practice my English very often, but I'll do my best. And I hope you all find this presentation valuable. Today, I'd like to share the philosophy behind our Stage 1 protocol. This philosophy goes far beyond aligning teeth. It combines orthotropics, functional training, and very important family participation to guide healthier craniofacial development. Rather than focusing only on where the teeth are, I'd like to ask a different question. Actually, I'm going to ask a lot of questions. This is the first one. How can we help a child grow better? And that's what this presentation is about. How can we help a child grow better? But before talking about stage 1, I'd like to start with another question. I told you there will be a lot of questions. Why are we seeing so many crowded teeth in children today? Many of these children present smaller dental arches, crowded dentition, and narrower airways. And that's probably not a coincidence. This has become a very common pattern. Maybe the teeth are simply showing us that the jaws did not develop to their full potential. When we look around today, crowded teeth seem almost normal. In fact, we're often surprised when we meet someone with naturally straight teeth who has never had orthodontic treatment, right? But if we look at historical populations, that was not the norm. Naturally well-developed dental arches and straight teeth were much more common. So something changed. To address all these problems, orthodontics already has powerful tools. We can align teeth, we can expand, we can improve dental and skeletal relationships. These treatments have changed many lives. So our question was never whether these treatments work. We all know they work. As orthodontists, our main goal is to align the teeth and achieve a stable, functional bite. And once we've done that, our next concern is preventing relapse. Because we all know long-term stability remains one of the biggest challenges in orthodontics. That was my way of thinking for many years. But over time, I realized I was asking the same questions over and over. How can I create enough space? How can I improve stability? Then I started asking different questions. The questions we are here to explore today. Why did this happen in the first place? What led to maxillary constriction and crowding? Is creating space enough? Yes, we know creating space is essential, but is it enough to solve all the problems we see in these children? We can expand, we can align, we can improve the bite, but if breathing, swallowing, and resting posture remains the same, are we really changing the system? One more question for all of us to reflect on. Are we treating the cause or only the consequence? For us in this protocol, creating space is not the final goal. Healthy function is. One of the biggest challenges in my own learning has been understanding function. In dental school, we were taught that function matters. But I don't think We were taught how deeply it influences growth and stability. And we certainly weren't taught how to help patients develop healthy oral functions. We all know that function guides form, yet function often receives much less attention than tooth movement. Today, that no longer makes sense to me. Our philosophy is built around three simple ideas. First, create the space. Second, train the function. And third, maintain the result. Muscles use the space that we create, but the treatment does not end when the appliance is removed. We have to learn and really understand this. Healthy habits are what make healthy growth sustainable. We all recognize a maxillary deficiency in growing class 3 patients. For us, is obvious. But what about many growing class 2 patients, like this one we see here? Could maxillary underdevelopment also be part of the picture? This question changed the way we started looking at many of our young patients. We know the maxilla is the foundation of the face. Many treatments focus on the mandible, but the mandible follows the maxilla, right? If the foundation isn't where it should be, how can we expect everything else to develop properly? We stopped looking only at malocclusions and started learning how to read the face. A patient may have a class 1, a class 2, or a class 3 relationship and still have an underdeveloped face. Occlusion alone doesn't tell the whole story. That's why we use the Volton template as a visual reference. It's the one you can see here in this slide. It helps us explain parents how much forward facial development may still be needed. It also helps us set goals that go beyond aligning the teeth and beyond malocclusion. Many of these children also present vertical growth, deep bite, gummy smile, or reduced mid-face development. Instead of asking, how can we improve the bite? We began asking, how can we guide the maxilla toward a healthier pattern of growth? And this is where stage 1 becomes a very important part of our protocol. So here it is. This is a stage 1 appliance. At first glance, stage 1 looks like a conventional expander. I know what you are thinking. And honestly, that's exactly what most people think the first time they see it, even parents. But it was never designed to behave like a conventional expander. Of course, it produces transverse expansion, but that's not the reason why we use it. We use it because it helps us accomplish several treatment goals with a single appliance. Besides transverse development, it also helps increase anterior arch length and provides us remarkable vertical control during growth. You will see. I will show you a case. For us, stage 1 is not simply an appliance. It is a tool that supports our treatment philosophy, everything we've been talking about so far. Let's start talking about function. One of the most important concepts in our philosophy is that rest should require very little muscular effort. When the tongue rests against the palate and the lips remain gently closed, the oral cavity becomes a sealed chamber. This allows negative intraoral pressure to develop naturally, instead of constantly using muscles to stabilize the tongue. Fluid dynamics begin to do part of the work. Our goal is not to strengthen muscles. The goal is a more efficient system. And this is what we call the up lock position. In our practice, we strongly believe that resting posture and swallowing are two of the most important functions for maintaining the width and the space we create during stage 1 treatment. I will play the video again so you can see it again. The up lock position. How can we get this position? The key is swallowing. We ask the patient to swallow 2 or 3 times, and it depends on the grade of dysfunction, but we all do this position or this posture after swallowing. With this suction, the tongue is held in the palate without effort, without using the muscles, and it allows the lips to seal. How can we teach this posture to our patients? Once the anatomy allows this new resting position, it has to become a habit. I think this is the hard part. That's why we use the up blocker. It helps children recognize, practice, and gradually adopt this new resting posture. We're not trying to give children stronger muscles. We're teaching them when muscles should work and when they should not. Rest is where efficiency begins. So as you can see, children can use this up blocker while doing any other activity, like watching TV, playing video games, doing their homework, and very important and interesting thing about this up blocker appliance is that it gives you feedback. When you are teaching a patient how to rest the tongue and the lips are sealed, we don't know if they are doing it right. Here with the up blocker, I'm going back here, you can see that the membrane of the up blocker goes in, and then you know that the patient is not only positioning the tongue in the palate, but doing this or creating with suction this negative pressure, which is very important for the airway to be totally completely opened, so the air could go through the nose effortless. And very important for people who snores, it is important to learn this posture to reduce this snoring while they're laying down. Why does nasal breathing matter? Nasal breathing shapes the face. That's what we think. That's why it is one of the main goals of stage 1. Because nasal breathing is much more than a way to bring air into our lungs. It is one of the main forces that supports normal craniofacial development. Healthy nasal breathing encourages proper tongue posture, lip seal, a forward mandible posture, and healthy development of the midface and maxilla. In other words, nasal breathing brings together many of the conditions needed for normal facial growth. For me, the most important one. And beyond facial development, we also know that healthy nasal breathing supports better overall health and well-being. Growth happens every day. We have to remember this. Because 1 hour in the clinic cannot compete with the other 23 hours of the day. Children grow while they sleep, while they eat, while they breathe, while they play, while they swallow. This is why parents become such an important part of the treatment. We can guide growth during appointments, but healthy habits are built at home. Our goal is not lifelong exercises. That is not sustainable. Our goal is lifelong healthy habits. And this sometimes is really hard for me because you need parents to know and to believe this to help these children. And very, very important also, timing matters. One of the greatest advantages we have is growth. Growth gives us opportunities that simply cannot be recreated later. In our experience, the most favorable window is during the primary dentition. At this stage, we are not just treating the problems we see today, we are helping guide the way the face will develop tomorrow. As children grow older, treatment often becomes more complex. We may need additional orthopedic appliances, comprehensive orthodontics, or a combination of different approaches. That is why for us, timing is just as important as technique. When we intervene early, growth becomes one of our greatest allies. Of course, we can treat older children, older than 12, but you will see the results are not the same. Also, it's a hard age. When they are teenagers, compliance is really hard. So it is important for parents to understand this, to understand that the better age is when they are still growing. So far, we've talked about the philosophy behind stage 1. Now I'd like to show you what that philosophy looks like in clinical practice. These are the patients who help me shape the way I think about early treatment. If you ask me what has surprised me the most about stage 1, my answer would be its vertical control. This was one of those patients who made me stop and think, wow, something different is happening here. She came to our clinic in the primary dentition. One of the family's main concern was her gummy smile. I know that not every patient is concerned about excessive gingival display, but some children and their families, it can have a significant aesthetic impact. What has impressed me most in my own clinical experience is the amount of vertical improvement we can often achieve during stage 1 treatment. In our clinic, this phase usually lasts about 6 months in children with complete primary dentition. And I think that is such remarkable changes in such a short time. Seeing this type of change in such a short period of time continues to surprise me every day. For me, this is one of the greatest strengths of stage 1 appliance. Another thing that continues to impress me is how much growth can still help us when we intervene early. This patient did not have a dramatic facial transformation. We can see her face look better, yes. But something else very important happened. We created the conditions for normal development. As the maxilla developed, space gradually became available for the permanent teeth. You can see here how much space we have. But my favorite image is the panoramic radiograph. Here we have the before and the after. And again, look how much space we have now. It's amazing. It reminds us that early treatment is not only about correcting today's problem, it is about creating better opportunities for tomorrow. Sometimes that means reducing the need for comprehensive orthodontics treatment. And when braces are still needed, they often become much simpler because we are working with a more favorable skeletal relationship and much less crowding. And for me, this is one of the greatest advantages of treating children while they are still growing. I'd like to finish with the case that had the greatest impact on me. Again, not because of the teeth, but because of the face. This little boy presented with a very vertical growth pattern. As treatment progressed, his face became progressively more balanced. His profile improved. His chin became more defined. You can see it here. His cheeks developed. You can see that new mid face. The entire face became more harmonious. Cases like this remind me that early treatment is about much more than creating space for teeth. It is about guiding facial growth while children are still growing. When I look at this patient, I don't just see straighter teeth. I see a child who had the opportunity to grow differently. And for me, that's what early treatment is really about. Create the space, train the function, maintain the result. As I reflect on everything we've discussed today, I always come back to these three ideas. Create the space, train the function, maintain the result. For us, stage one is much more than an appliance. It is a philosophy that combines growth, function, and family participation. Our goal is not simply to create beautiful smiles. Our goal is to help children reach their full potential and growth into healthier adults. Thank you very much.